multiple organ dysfunction syndrome. Kareem Rafat, MD. Favorite quotes from my search. The triad of death. When good cytokines go bad. The fast death pathway in mods, not so fast. Sepsis and hypovolemia, too bad. Tempering the temptation to treat with Temp-Pol. The goal of therapy may not be to restore order but, rather, to restore fractal, multiple scale variability. Limitations of term mods. Mods is a wastebasket diagnosis. It can mean a lot of different things. Mods has many historical synonyms. Multiple, remote organ system failure. Sequential, progressive system failure. Systemic inflammatory response syndrome, SIRS. MODS is a final common pathway. Like cardiorespiratory failure. MODS is heterogeneous clinically. Varies by organ systems affected, severity, etc. MODS, general concepts. MODS is comprised of the activation and dysregulation of multiple complex overlapping physiologic systems. Overall, hormonal, cytokine, and immunologic changes leading to systemic inflammation, a procoagulant state, and organ dysfunction. MODS, general concepts. Increases stress hormones. Catecholamines. Cortisol. Growth hormone. Glucagon's. Insulin. MODS, general concepts. Immune system activation. Complement activation. Neutrophil and macrophage activation. Free radical liberation. Toxic oxygen metabolites. Immune-mediated pro-inflammatory. Peptides. Cytokines. Bioactive lipids. MODS, general concepts. Inflammatory cytokines. Many involved, major players listed. Tumor necrosis factors, TNF. Interleukins, IL-1 beta, IL-6, IL-8, IL-4, IL-10. Interferons. Cytokine receptors and receptor antagonists. MODS, general concepts. Procoagulant state. Shift in tendency of coagulation system. Endothelial injury and dysfunction. Fibrinolysis inhibited. Protein C depletion. MODS, general concepts. Increased metabolic demands. Increased oxygen consumption. Increased gluconeogenesis. Increased protein catabolism. MODS, general concepts. Feed-forward cycle. Metabolic/inflammatory/immunologic responses become generalized and persistent, even in absence of original stimulus. Increased demand on organ function promotes failure, CO, ventilation, oxygenation, nutrition, fluids, excretion of waste. Organ failure causes metabolic/inflammatory/immunologic responses. Hypoxia, ischemia, cell death, inflammation. Major cytokine mediators. TNF-alpha, 1. Produced mainly by macrophages and neutrophils. Response to many stimuli. Very early expression in almost any major inflammatory response. Sustained increased levels in many conditions, trauma, burns, severe sepsis. Levels correlate with mortality. Major cytokine mediators. TNF-alpha, 2. Amplifies inflammatory response. Stimulates release of other pro-inflammatory cytokines, lipids. IL-1, IL-6, eicosanoids. Upregulates adhesion molecules on endothelial cells and PMNs. Enhances a number of neutrophil functions. Phagocytosis, degranulation, chemotaxis, free radical formation. Upregulates enzymes and parallel inflammatory cascades. phospholipase A2, COX, and nitric oxide synthase. Upregulates coagulation inhibitors. Endothelial cell alteration, vascular permeability edema. Myocardial depression. Fever. Vasodilatation, nitric oxide, hypotension. Major cytokine mediators. IL-1 beta. Produced by a variety of cell types. Increased release of pro-inflammatory cytokines, lipids. TNF, IL-6, EMF. Endothelial cell activation and prothrombotic stimulus, TF. Increased adhesion molecule expression. ICAM, CAM, selectins. Myocardial depression. Fever. Vasodilatation, nitric oxide, hypotension. Major cytokine mediators. Pro-inflammatory cytokines. For example, IL-6, IL-8 and interferon gamma. Promote immune cell-mediated killing. Anti-inflammatory cytokines. For example, soluble TNF receptor, IL-1 receptor antagonist protein, IL-4, and IL-10. Turn off the immune response when infection/stimulus has been cleared. Major cytokine mediators. Cytokines out of control. Peroxynitrite, 1-, can cause DNA damage. Cell program and function deranged. Activation of poly-ATP ribose synthesis. Deplete cells of NAD+ and ATP. Leads to secondary energy failure. Overactivated immune cells release Fas and Fas ligand. Prevents activated immune cell apoptosis. Promotes ongoing inflammation. Ineffective and unresolving inflammation. Leads to systemic organ failure. MODS, genomics research. Genomic microarrays. Models. Animal models of ALI/ARDS, sepsis. Function. To determine gene expression patterns. Disease attributes. Variance in cytokine expression patterns between MODS subsets. Host attributes. Impact of cytokine polymorphisms in the same MODS subset. MODS, genomics research. Genomic microarray results, some examples. TNF beta-2 homozygotes. Greater amounts of TNF in septic shock can have significantly higher mortality. TNF alpha promoter polymorphism plus TNF beta-2 allele. Higher incidence of septic shock and mortality. By 1 polymorphisms. Worse outcome with purpura fulminans, susceptibility to meningococcal sepsis. IL-1 receptor antagonist polymorphism. Increased risk of developing septic shock. FCA receptor genetic polymorphism. Decreased clearance of bacterial infections and poor outcomes. Toll-like receptor 2 polymorphism. Susceptibility to severe staphylococcal infections. MODS, genomics research. Identification of pre-cytokine control. Finding ways to turn on key shock proteins, viral vectors with HSP promoters proven to be protective in OLI models. Identification of transcription factors and gene expression modulators that control intracellular and humoral cytokines. MODS, genomics research. Example of a signal further upstream. NF-kappa B promoter pathway linked to ARDS and is associated with the expression of cytokines. TNF alpha. IL-1, -2, -3, -6, -8, -12. Eotaxine. Gro alpha, beta, and gamma. MIP-1 alpha. MCP-1. Adhesion molecules. ICAM-1. CAM-1. Aselectin. Growth factors. GM-CSF. GCSF. MCSF. Miscellaneous. Inducible no synthase. CRP. 5-lipoxygenase. Inducible COX-2. SIRS sepsis mod spectrum. Epidemiology suggests there is a general progression of pathologic states. SIRS, sepsis, severe sepsis, septic shock. Mods. SIRS sepsis mod spectrum. Defined as greater than or equal to 2 of the following. Temperature abnormality. Greater than 38 degrees Celsius or less than 36 degrees Celsius. Hemodynamic distress. Tachycardia. Respiratory distress. Tachypnea, hypercarbia, or hypoxia. Inflammatory marker. WBC greater than 12K, less than 4K, bands greater than 10%, CRP greater than 2 SD high. SIRS sepsis mod spectrum. SIRS plus. Confirmed infectious process, or strongly suspected infection. Severe sepsis. Sepsis plus. Organ dysfunction. Various organ failure scores exist. SIRS sepsis mod spectrum. Septic shock. Definition: sepsis plus greater than or equal to one of the following. Decreased peripheral pulses, compared to central pulses. Capillary refill. Greater than 2 seconds, cold shock. Mottled or cool extremities, cold shock. Flash capillary refill, vasodilated, warm shock. Decreased urine output, less than 1 ml/kg per hour. Other shock notes. Hypotension observed in late decompensated shock. Shock in children also classified by response to therapy. Fluid responsive, refractory. Dopamine responsive, resistant. Catecholamine responsive, resistant. Refractory shock. SIRS sepsis mod spectrum. Definition: progressive reversible dysfunction of greater than or equal to 2 organs from acute disruption of normal homeostasis requiring intervention. Primary mods. Immediate systemic response to injury or insult. Less than 1 week in ICU, better prognosis, 85% of PEDS cases. Secondary mods. Progressive decompensation from host response and second hits. Greater than 1 week in ICU, worse prognosis. Mods progression, a typical sequence of organ system dysfunction. Circulatory insufficiency. Tachycardia, hypotension, myocardial depression, CHF, arrhythmia. CNS depression. Agitation, lethargy, coma. Respiratory failure. Tachypnea, hypovent, hypoxia, hypercarbia, pulmonary edema, ALI/ARDS. Renal insufficiency, failure. Fluid overload, uremia, electrolyte derangements. Hematologic derangements. Anemia, hemolysis, thrombocytopenia, coagulopathy, DIC, consumptive hemorrhagic complications. Gut/hepatic dysfunction. Ileus, cholestasis, bacterial translocation, gastritis, malnutrition, poor synthesis. Endocrine dysfunction. Insulin resistance, hyperglycemia, adrenal insufficiency. Immune system. Cellular and humoral immune suppression. Mods scoring multiple scoring systems. Brussels score, mod score, sepsis-related organ failure assessment, logistic organ dysfunction score. Mod score presented as an example. 6 organ systems included. 1 physiologic variable is used to describe each organ. No consideration of therapy. A score of 0 reflects essentially normal function. Isolated ICU mortality rate of less than 5%. A score of 4 represents severe physiologic derangement. Isolated ICU mortality rate of more than 50%. Score range, 0 to 24. Mod scoring 1 2 3 4 organ system measure respiratory greater than 300 226 to 300. 1 2 3 4. Respiratory. PO2/VO2 ratio greater than 300. 226 to 300. 151 to 225. 76 to 150. Less than 75. Renal. Serum creatinine, mol/L. Less than 100. 101 to 200. 201 to 350. 351 to 500. Greater than 500. Hepatic. Serum bilirubin, mol/L. Less than 20. 21 to 60. 61 to 120. 121 to 240. Greater than 240. Cardiovascular. Pressure adjusted HR. HR/CVOP/MAP. Less than 10.0. 10.1 to 15.0. 15.1 to 20.0. 20.1 to 30.0. Greater than 30.0. Hematologic. Platelet count, X103/L. Greater than 120. 81 to 120. 51 to 80. 21 to 50. Neurologic. Glasgow Coma score. 15. 13 to 14. 10 to 12. 7 to 9. Less than 6. Mod subset. Thrombocytopenia-associated multiple organ failure or disseminated intravascular coagulation, DIC. Characterized by unopposed tissue factor, TF, and plasminogen activator inhibitor type 1, by 1, activity. Consumption of coagulant and anticoagulant factors. Deficient VWF cleaving protease activity, increased ultra-large VWF multimers. Special consideration. Plasma exchange, P, replaces VWF cleaving protease, removes ultra-large VWF fragments, normalizes by 1 activity. Kids W/3+ organs down plus low PLT have shown resolution of organ failure and improved outcome with prolonged P, mod subset. Unresolving multiple organ failure and infection or prolonged monocyte deactivation. Characterized by monocyte HLA doctor expression less than 30% for greater than 5 days. Ex vivo TNF-alpha expression to LPS stimulation less than 200 for greater than 5 days. Can be caused by overwhelming Th2 milieu, for example, exogenous immunosuppression. Free radicals. Special consideration. Monocyte function needed to kill infection and clear antigens. Can be accomplished with rapid weaning of immunosuppression. Interferon or GM-CSF in patients not receiving immunosuppression. Mod subset. Prolonged lymphopenia, superinfection, and unresolving multiple organ failure. Characterized by prolonged absolute lymphocyte count less than 1,000 for greater than 7 days. Increased incidence of death from secondary infection. Associated with prolonged hypoprolactinemia in children. Special consideration. Monitor CD4 count and gamma globulin levels. Appropriate prophylaxis for pneumocystis, fungus, and hot S found broader empiric coverage in secondary sepsis. IVIG should have hypogammaglobulinemia. Prolactin is an anti-apoptotic hormone for lymphocytes, but it's unknown whether prolactin replacement is beneficial. Use of drugs associated with hypoprolactinemia or lymphocyte depletion should be stopped when possible, for example, dopamine. Mod subset. Sequential multiple organ failure with viral infection or lymphoproliferative disease. Characterized by association with lymphoma and post-transplant lymphoproliferative disease. EBV, plus, lymph nodes and serum PCR. Lymphocyte fast ligand-mediated apoptosis contributing to liver failure. Special consideration. Treatment with monoclonal antibodies to B lymphocytes, mod subset. and resolving acute respiratory distress syndrome without infection or fibroproliferative lung disease. Characterized by ARDS at 1 week with no infection by BAL or BX. Increased IL-6 levels. Normal lymphocyte count, monocyte HLA doctor expression, and ex vivo whole TNF-alpha response to LPS. Culture negative bronchoalveolar lavage, BAL, fluid. Fibrine deposition. Special consideration. Treatment with steroids in fibrinoproliferative stage. Methylprednisolone dosage. Epidemiology and mortality. Mortality of pediatric septic shock. 1963, 97%. 1973, syndrome of Maud first described. 1985, 57%. 1991, 12%. 1995, 10%. 1999, 5 to 9%, nearly all dying of MODS. About 50% higher in children with chronic illness. Epidemiology and mortality. MODS has emerged as a consequence of the advances in intensive care, drugs, and technologies. Multiple and overlapping definitions have made research in epidemiology difficult. Severe sepsis with associated MODS is the leading cause of death in adult intensive care units. Has the highest mortality in PICUs. Mortality depends largely on definition used for MODS. Overall, mortality improving as therapies improve. Epidemiology and mortality. MODS mortality increases with advancing age or prematurity. Of dysfunctional organs. Prolonged organ failure. Delayed diagnosis. Delayed or inadequate resuscitation. Inadequate source control. Inadequate NIDS removal. Ineffective antibiotic regimen. Epidemiology and mortality. MODS mortality increases with delay of therapy. For every 1 hour with hypotension or cap refill greater than 2 seconds, severity adjusted mortality or equals 2.0 in kids with community-acquired sepsis. Care model. Managed care gatekeepers and delayed access to care have been associated with poorer outcome from septic shock. Epidemiology and mortality. Adults MODS. Mortality 20 to 100%. Organ systems down. 140%, 260%, 395%, 100%. Sepsis in greater than 70% of cases. PEDS MODS. Mortality 26 to 50%. Accounts for 5 to 30% of PICU census. Accounts for till to 90% of deaths. Sepsis in less than 50% of cases. Epidemiology and mortality. PEDS MODS with severe sepsis. Till to 50% newborns. Greater than 50% of those preterm. Till to 50% pediatric. Greater than 50% of those with chronic illnesses. More children die in association with severe sepsis, MODS than die from cancer. Annual healthcare costs in US $4 billion. MODS Rex, general. No specific effective therapy for all forms of established MODS. Effective preventive and therapeutic strategies exist in pre-MODS syndromes/pathologies. Mainstay of non-preventive therapy is supportive care for individual organ failure. Optimizing organ function, oxygen delivery, cardiac output, early enteral nutrition. Replacement therapies, mechanical ventilation, CVVHD, ECMO, hepatic dialysis, MARS. Many models and theories of how to manipulate complex signaling and cytokine storm through molecular therapy. MODS Rex, prevention MODS prevention general, primary MODS. Rapidly identify and eliminate event-citing stimulus before host response becomes zone feed-forward stimulus. Primary MODS. Measures to decrease multi-system injury/trauma/illness through avoidance of first hit in a vulnerable demographic. For example, protective gear, child seats, immunizations, etc. Secondary mods. Measure to forestall progression of SARS or sepsis to mods through avoidance of second hits in a prime system. For example, rapid medical access, EMT, special teams, stroke team, code blue, infection control policies, clean units, mods RX, good evidence severe sepsis in mods. Appropriate antimicrobials. Early empiric antimicrobials. Timely conversion to infection-specific therapy. Antibiotics with best mic. Early goal-directed hemodynamic and O2 delivery therapy. Normal BPW/IVF and SVCO2 sat greater than 70%. Achieve with oxygen plus PRBC plus inotropes. Activated protein C. Adjunctive immune therapy. GCSF/GMCSF for neutropenic patients, especially newborns. Steroids/IVIG/etc. in selected cases. Pentoxifylline. Realogic agent demonstrated benefit in premature infants. Mods RX, good evidence septic shock in mods. Use of hydrocortisone plus fludrocortisone. For patients with a minimal cortisol response to corticotropin stimulation. Careful vasopressor selection in patient population. For example, avoidance of alpha agents in neonates. ECMO in selected cases. Benefit greatest in neonates greater than children greater than adults. Mods RX, good evidence ARDS and mods lung protective ventilation. Low stretch ventilation, prevent VLU trauma. Open lung, prevent de-recruitment, sharing. Steroids in proliferative phase. Criteria. Unresolving ARDS, greater than 1 week. Culture negative, by BA. Decreases fibrin deposition. Mods RX, good evidence ARF and mods renal replacement therapy. CVVHD greater than daily dialysis greater than intermittent dialysis. CVVHD appears to alter cytokines favorably. Address abdominal compartment syndrome. PD catheter for decompression, mods RX, good evidence other problems in mods hyperglycemia. Insulin therapy. Normoglycemia improves outcomes in ICU patients. Hypogammaglobulinemia. IVIG. Broader empiric antimicrobial coverage. Immunosuppression in mods. Cessation of immunosuppressants. Broader empiric antimicrobial selection. Mods RX, controversial. Many controversial therapies. Dickon mods. Anticoagulants in selected cases. Prudent factor, blood product replacement. Free radicals in mods. Scavengers, NAC, persistine, Tempol, retinol, tocopherol, and beta-carotene, vitamins E and C. Animal models have shown benefit but no proven benefit in hard endpoints in human trials. Mods, the future. Attempts to modulate the complex inflammatory responses of SARS sepsis mods must address the heterogeneity of the process in the host. What's needed? Larger multi-center RCTs to adequately power studies as mortality percentages fall. More refined definitions and consistent usage of the SARS sepsis mod spectrum. A better understanding of what is common to all patients and what is associated with host variations, for example, gene polymorphisms. SARS sepsis mods, then and now. Do not give more than 20 ml/kg. Give at least 60 ml/kg of fluid. Do not use epinephrine or norepinephrine. Use epinephrine or norepinephrine, age-specific dopamine insensitivity. Steroids are bad. Give hydrocortisone for both classic and relative adrenal insufficiency. Patients have a high cholovascular resistance state and die of vascular failure. Children can have any hemodynamic state, frequently have high vascular resistance, and commonly die of cardiac failure. Use vasopressors, not inotropes, vasodilators, or inodilators. Vasopressors are required for some, but inotropes, vasodilators and inodilators are required. Pentoxifylline is effective for premature infants. Search sepsis mods, then and now. ECMO does not work. ECMO does work. Do not use inhaled nitric oxide. Use ENO for PPHN. Maintain a normal PCO2. Use an effective tidal volume of 6 ml/kg and minimize volutrauma. Hemodialize/filtrate patients with acute renal failure as infrequently as possible. Hemodialize/filtrate patients with acute renal failure daily. Ignore DIC. It will get better when shock resolves. Aggressively reverse DIC, thrombosis and bleeding is bad. O2 utilization goal-directed therapy isn't important. Maintain normal perfusion pressure and SVCO2 saturation greater than 70%. Do not worry about hyperglycemia. Maintain normal glycemia. Use insulin. Search sepsis mods, then and now. Sensitive means sensitive. Use antibiotics with MIC less than 1. Children die because they have too much inflammation, white blood cells are bad. Children die because they cannot kill infection. Stop treatment with immunosuppressives, give GM-CSF for neutropenia, IVIG for hypogammaglobulinemia. There is not much you can do for septic shock but pray. Nobody understands MOF. Septic shock is reversible. MOF equals untreated thrombotic microangiopathy or uneradicated infection. TTP is a hematologic disease, not an ICU problem. TTP-like pathology is present in children with TMOF. Prolonged plasma exchange can reverse pathology. Secondary infection and resolving MOF is a mystery. Monocyte deactivation and lymphoid depletion occur. Rapid tapering of immunosuppressives and use of GM-CSF or interferon can be helpful. Unresolving ARDS without infection is incurable. Steroids can reverse unresolving ARDS without infection. Multiple organ dysfunction syndrome. Take everything you hear with a grain of salt. When we look back a decade from now, what will we believe is wrong with what we are doing now? Primum non nocere. Pop quiz. 1. At least how many organ systems need to have dysfunction to count as multiple organ dysfunction syndrome, MODS? A. 1. B. 2. C. 3. D. 4. Pop quiz 2. Which of the following statements about MODS is false? A. Primary MODS, initial insult, has a better prognosis than secondary MODS, second hit. B. MODS with sepsis may benefit from CVVHD, even if there is no overt renal failure. C. MODS is accompanied by infection/sepsis more commonly in children than in adults. D. Most management in MODS is supportive.